Hello, I'm David Prophet with Vascular Anesthesia,
And I'm Crystal North with Vascular Anesthesia.
and this is Insomnia.
I fell asleep last night, got teardrops on my pillow. I have no peace of mind, and this might never change. Never change.
Today we have a great show. We're going to share with you some information about some anesthesia that usually is not talked about a lot and kind of misunderstood, misperceived in a lot of communities. First, we're going to talk about some questions about anesthesia, OSA, which is the questions that people have about anesthesia, which is obstructive sleep apnea, which occurs in a huge amount of patients that we have.
Yeah. So obstructive sleep apnea, a question that when we do our interview at the beginning of our meeting is, we'll ask the patient, do you have sleep apnea or do you have obstructive sleep apnea? And a lot of times they'll say, oh no, I don't have any problem sleeping. Mm-hmm. But what we're really asking is about, do you snore at night? Mm-hmm. Do you wake yourself up sleeping? Mm-hmm. Are you sleepy after you just woken up mm-hmm. because you didn't sleep restfully? And, also do you have headaches when you wake up?
Yeah, and a lot of people, they are not readily available to give you that information. Some of these people are on home oxygen. Some of these people are on CPAP machines. And we always ask that question because it can be a huge anesthetic complication when we start doing your emergence, when you start to wake up. And it can potentially be a problem in the PACU when you have a nurse out there trying to make sure that you're okay and taking care of you in the recovery room.
Yeah, that's a lot of times where you see a huge complication with sleep apnea. Yes. Because then those patients fall asleep mm-hmm. and they obstruct. Mm-hmm. It causes them to stop breathing, their mm-hmm. oxygen saturations drop, and if no one is paying attention or if that nurse is, helping someone else, she might not notice, and, you could be without, or low oxygen saturation for, a few minutes, mm-hmm. Which more than likely these people, wake themselves up, but it is a complication that sometimes happens, unfortunately.
So when we go to see them in pre-op, it's a couple things that we kind of look out for. Some of these individuals, they have huge necks,
Yes.
Huge necks. They're not able to extend their neck a whole lot. Mm-hmm. When we do 3 finger breaths, it's usually probably around 2. Mm-hmm. Or these are some of the people that come in and they have no neck at all.
Right. Very short, wide necks.
Mm-hmm. Very mm-hmm. short, wide. And it's hard to ventilate these people sometimes.
Very.
You have to put oral airways in. Mm-hmm. Other people are hard to ventilate are people with beards,
Yes.
And they have these big beards. I know it's in style right now, but y'all are hard to ventilate,
Very hard. The beards and the mustaches sometimes.
Yes. So when these OSA patients come in, we kind of key in on, the thick neck, obesity. Mm-hmm. And that's when we start getting a little deeper into your business, asking you questions like, hey, do you snore? Do you feel tired at night? Are you restless? Do you wake up all the time during the night? Are you on oxygen? Are you on a CPAP machine? And most of the times we have patients that tell us the truth, and they mm-hmm. very honest with us and let us know, like, hey, I have problems breathing at night. I have problems I wake up all the time, restless, mm-hmm. and I don't have a good night's sleep.
Right. Or you get those patients that say, oh, yeah, I have a CPAP machine at home, but I don't wear it. Mm-hmm. And if the doctor gave you a CPAP machine, then you should use it because that means that it is indicated. And when we say indicated, we mean it's for you.
Right. So imagine when this patient and they're at home and they obstruct. Of course they obstruct. They go home, they obstruct. Their SATs are probably in the 80s, 70s, probably even longer mm-hmm. until they wake up and, that's what you hear. And it's long and it's this buildup of carbon dioxide. And
put stress on your heart.
Yes, it does.
Mm-hmm.
It can cause heart problems. And it can basically change your whole makeup of what you do and how you living. So some things that you need to do that we will always say. Number one thing is obesity. Number two, smoking. People who smoke, they have OSA. They're not able to do anything. And it's not a thing where, hey, this person is have obesity, have OSA. We have skinny people with OSA.
Yes.
A lot of people, they come in and they are snoring, they are chopping wood and they sleep,
Yes.
and you can just hear them from down the hall. That's
Yep.
why usually when I talk to a male, I go to him, I don't even ask him, I ask the wife, and I'm like,
Yep.
is he chopping wood at night? You know, is he snoring so bad? Oh, I can't sleep at night. You know, he
Right.
wakes me up all the time.
That's usually who you have to ask. You have to ask the spouse because they're the ones who are going to tell you, oh, no, he snores. I have to, wake him up. Sometimes he stops breathing. And those are the things that we want to know about because we are putting you to sleep.
Yeah.
So if they stop breathing, we want to know because so that we can know to expect it.
Yeah, especially doing MAC anesthesia, right?
Right,
Um,
right.
MAC anesthesia, usually we giving drugs, keeping them still, and you can institute a lot of things. You can put an oral airway, nasal airway, and try to combat this sleep apnea. But like I said, once again, it's in recovery when we have problems. Now, it's things that we do during MAC anesthesia where we say, you know what, I'm gonna give him a little less fentanyl, or I'm gonna try to alter his anesthetic where the sleep apnea won't be a problem in recovery. We may go a little more, maybe ketamine, or we may go heavy propofol. It's
Right.
certain things that we can give to this patient that can combat the OSA.
Right. That magic drug ketamine that we talked about
Yes,
last week,
yes.
it is a wonder. Like I said from last week, it's one of those, medicines that's going to drive your respiratory drive. So it's going to keep you breathing. And, with opioids like the fentanyl, which can slow down your breathing, it kind of levels it out. And that's part of the education, and that's why you need anesthesia.
Yeah.
That's part of our job is to know those things. But
But doing and often doing surgery, general anesthesia, where we completely put you to sleep, which involves a lot of things. It involves propofol, fentanyl, Versed. We'll paralyze you. Of course, that's going to call for a breathing tube, an endotracheal tube, which we will put into the patient using laryngoscope. We go down, use a laryngoscope, and we place it into the, basically in layman's term, put in the top part of your lungs.
Yep.
And put in, where you're able to breathe from the breathing machine. The anesthesia machine will give you gas, keep you asleep. A lot of people don't know that. They like, how are you gonna, how is it gonna hurt after, the
Right,
tube? They don't know anything about the OSA, complications in the back, stressing on the heart, or anything like that. They just like, hey, are you gonna take care of me? Am I gonna be okay?
absolutely. If we put a breathing tube down, we're going to be there every second to watch to make sure that you are okay. We don't ever leave you during an anesthetic.
We are vascular. We provide anesthesia services for office-based anesthesia, ASCs, and even small hospitals. Thank you for the opportunity that you allowed us to come in to your families to service you while you're sleeping with excellence. Thank you. We are vascular.
We are vascular.
I fell asleep last night, watching drops on my pillow.
Just a general question: is OSA is it a problem? Is it a contraindication that we can't give anesthesia because of that?
No,
Right.
no,
Absolutely
it's
not.
not.
So, like I said, we can alter the anesthetic to fit each patient. It's not a cookie cutter anesthetic for everyone.
Right.
Everybody, they have different drugs, and we make sure that they're taken care of. We formulate a plan to make sure that each patient outcomes are great, where one, they're pain free. Anesthesia is not all about sleep, it's about pain free. If they have it that bad with MAC anesthesia, maybe we can do a block. Depends on, what's going on. If we're doing an ankle, if we're doing a toe, we can do an ankle block. But they can do femoral blocks, popliteal blocks around the knee. They can even do get your scalene blocks up top if they're doing shoulder surgery, so supraclavicular blocks, so infraclavicular blocks. You know, it's a lot of things that we can adjust your anesthetic to make sure that you are well taken care of doing your surgery.
Right. Yeah. The regional anesthesias really help when you need to kind of go lighter with the general anesthesias and the MAC anesthesias. They really help.
Yeah, because also we're talking about, you know, most people have questions, do they stop breathing during procedure? And we're still sticking to OSA before we really go into that, because at home you actually probably stop breathing if you have OSA.
Oh, absolutely. You stop breathing, and then after, you know, so long, your body is able to finally, you know, get a breath in, and that's the snore that you hear. You know, it's when it's that obstruction and you hear air passing by the obstruction. That's where the snoring comes in. That's the snoring.
And usually, basically, our drive to breathe is carbon dioxide.
Yes.
It builds up enough where you're going to start back breathing. But if you have a thick neck or you have OSA, it is, you know, it's a battle. It's a battle at home with no drugs.
It's a battle, especially in what I like to call redundant tissue. And that's just when it's, you know, it's almost like a muscle. There's just so much, you know, tissue and,
thick
you know,
neck.
it's that thick neck.
Yeah.
It's just really that thick neck. And you trying to, you know, breathe through that, and it doesn't move. And these are the people that you see turn like this. You know, because their necks are, you know, short and thick, and they have the sleep apnea is with them.
Got that Mike Tyson neck on. They ain't moving at all. Just straight up, just thick neck. You know, football for
like when you have
know.
a crook in your neck.
Yeah. But these people are actually, you know, they're very afraid of anesthesia. But you know, they provide anesthesia themselves when they go home, when they drink like crazy, and then they go to sleep. And whatever extracurricular activities they participate in.
Absolutely. No judgment. We just want to know what you're doing.
We just want to know what you're doing so we can adjust.
That's right.
So we can do what we do.
So that's exactly. so we can know how much you have helped us.
Yeah, you know, it's anybody can go to sleep, but we want to keep you safe while you're asleep.
It's always about being safe and having a safe anesthetic in the end.
Right. So that's one topic that we want to talk about. Another topic we're going to talk about is a couple questions that we have. So one of the questions that we have is, how common is it for patients to stop breathing after general anesthesia?
After general anesthesia? Well, like we talked about, especially like in the PACU, you know, if you have sleep apnea, it's very possible that you may stop breathing. Some of the pain medicines that we give you, they cause you to slow down breathing, and if you've received too much, it can cause you to stop breathing. However, what we usually like to do as providers is we usually like to give you enough medication to keep you comfortable so that you're breathing efficiently when you get to the recovery room. That way, if you need anything else, you're able to ask the nurse there, and they can give you some medications that are a little bit, that are not as strong and that are more conducive to wherever you're going.
Well, let's kind of walk them through from the beginning when they get there and pack you all the way to basically us extubating the patient and taking them to recovery.
Okay.
So let's take a male first, right?
Okay.
We're gonna do it a little different, you know. We usually start with the females. Males are always scared, you know. They come in all macho, talking about they not scared, but you can see their heart rate is about, you know, 120.
120s, 130s. You talk about, you know, putting the IV in, and they get scared.
Oh, they pass out too. You know, they pass out on IVs. Oh, I don't like needles, and you know,
holding fists, you know, and just real stiff.
Oh, we had them all blowing hard. Let me hold your hand. Let me hold your hand. Ooh, they blowing hard. You're like, really?
Right. It's break out into a sweat, turn red.
Farting, everything. They be doing it all. They be doing the most. They be scared.
They really do. They really do.
And then they be trying to act macho. They be having the covers all
right. So that you can only see this, but we still know you're scared.
Right. Trying to act tough. his boy's sitting over there like, Dad, I don't know what's wrong with Dad.
He's scared.
Yeah, the wife come up there. I don't know. We are vascular. We provide anesthesia services for office-based anesthesia, ASCs, and even small hospitals. Thank you for the opportunity that you allowed us to come in to your families to service you while you're sleeping with excellence. Thank you. We are vascular.
We are vascular.
I fell asleep last night. Drops on my pillow.
So what we tend to do to these patients, so when they first come in, and they have an IV in, we talk to them and we build that trust with them. You know, we gain a rapport with them, and we get them where they trust us and when they're gonna be taken care of.
Right.
Then we give them benzodiazepine, we give them Versed.
Yes.
Kind of calm them down, decrease their anxiety. So these drugs are, you know, it'll calm you down. Some people make a little sleepy, a little woozy, and for ladies, some ladies, it can put them out.
Yeah, it can put you to sleep. We give you a small amount, but you know, it's just enough to take the edge off. That's what I like to say. It takes the edge off. It's kind of some I don't care medicine, you know, kind of put you in a nice, you know, relaxed place,
Right.
you know, before we wheel you back.
So after that, we taking you back. So when you get back, everybody think it's like Grey's Anatomy or something. It looks different than on TV. I'm like,
Right.
this is not TV.
It is not Grey's
And that
Anatomy.
blade is going to cut you.
She
So-
absolutely is.
Yeah. So they come in, they see the lights.
Yes.
And of course, it's stage fright, right?
Right.
They get a little scared, you know. And
Yeah.
I would be too.
Right.
And then, you know,
Get you over on the table, hook you up to some monitors. We're going to always monitor your heart. We're going to monitor your blood pressure. We're going to monitor your oxygen saturation. And we're always going to give you some type of oxygen, but that can come later. But those three things we will always do no matter what. Heart, oxygen, and your blood pressure.
okay. So after that, let's go before that.
Okay.
Patient come in pre-op and say, I don't want to do this, which has happened, right?
It absolutely has.
What do
It's
we
your-
do? What do we do?
That's their right.
Yeah. So they have rights. Patients have rights where basically if they say we're not doing this today, we're not doing this today. You can get charged with battery. You can get charged with assault. And you don't want to get in a situation where you have that. So we try to keep the patient as comfortable. We try to keep the patient as calm before we go back and make sure that the surgeon is explaining what is really going on with
Right.
what they're having. Because a lot of times the surgeon never talks to the patient, break down the communication, and they're scared.
Right. If a patient tells me, I don't want to do this today, I immediately go and try to find the surgeon and whoever the pre-op nurse is, or, you know, one of their representatives. Because if they're telling me that they don't want to have surgery, I'm not doing the cutting, I'm doing the putting to sleep. So, you know, something needs to be explained to them. So, I mean, I immediately, okay, I understand what you're saying. Let me go get someone that can talk to you.
Yeah, and we've had this problems. It
happens. It happens a lot.
Yeah, I've even had patients say, I think I'm going to die today. And I say, I think you need to go home, especially if it's an elective case. If it's an elective case, I'm like, you know, just go home.
Yeah.
If you think you're going to die today, not today.
I don't like to put patients to sleep on gloom.
Yeah.
Gloom and doom. If you
yeah.
feel like you're going to die, we need to do something to change that.
If it's
because you can't go to
elective.
sleep like that.
No, you can't. Emergency cases, you going to sleep, buddy.
You go.
So, especially if you need it, unless you're saying, you know what, I don't want to do it, I don't care. Hey, we can't touch you. We can't give you drugs if you don't want it. So, but going back to patient being hooked up on the bed and he's being monitored. He looks at the anesthesia machine and basically we start giving you a little oxygen.
Right.
We give you some medication, a little propofol, you know, a little fentanyl. While we're doing all this, you're still being monitored.
Right.
We're not leaving. Most
Nope.
people think you get a meds and say, I'm out.
Yeah. No,
I'm
we
going,
do not
I'm
do
going
that.
to eat me some Papa Do's in the back. I got to warm up.
It will Papa those would be so nice.
That sounds real good.
It absolutely does.
Those
At
hospital
work,
cookies are nasty, you know. And the lunch
Just
depends on where you go.
go for the fruit. Go for the fruit.
Go for the fruit. But you start giving them these drugs, and you basically start in general anesthesia. They have, we paralyze them either with rocuronium or sucks. After we get propofol, fentanyl, and the Versed has been given, we make sure that we can breathe for them.
Absolutely, that's really important.
We make sure we can breathe for them, and then give paralytics, and then we put the breathing tube in. So it sounds as simple as that because we didn't put so many people asleep.
Right.
I mean, we've been doing this over 10 years, so this is what we do.
It's muscle memory now at this point in time.
And everybody, they're scared, but this is what we do for a living.
Yes.
You know, builders build houses, pastors preach.
Yes, they do.
And we put people to sleep.
We put people to sleep.
So that's what we do for a living, and they always ask, are you afraid? Are you scared? No.
That's where we're comfortable. Yeah.
That's what I do.
That's what we do.
Now, some things that do happen that you don't know about, sometimes your heart rate or your blood pressure, it may drop a little bit. But it's normal because we are inducing anesthesia. We're giving you drugs. This is what happens.
The drugs are designed to do that.
So this is general anesthesia.
Yeah.
And we turn on the gas. The gas of our choice is 3 of them usually. It's desiflurane, it's sevoflurane, and it's isoflurane. So usually we use sevo. More than likely, and if they have obesity or anything like that, we turn on a very low dose of desiflurane. Increase in des will cause your heart rate to go up, so we keep it kind of low. We make sure that you're okay, that you're well taken care of, and basically that's general anesthesia. Now, the question is, how common is for patients to stop breathing after general? They stop breathing, but usually when we intubate the patient, use a laryngoscope, when we put in a breathing tube, we hook you to an anesthesia machine. It breathes for you when we paralyze you. Or a LMA. If it's a quick case, it's a laryngeal airway. It slides in. You use lube. It doesn't actually go down into your lungs. And it's a little softer when you wake up. The sore throat is not as bad or whatever. And everything's good as far as the patient waking up. So do they stop breathing? Yes and no. But yes, you stop, but we hook you up to anesthesia machine and it breathes for you if we paralyze you, if they have to go into your belly and do any type of abdominal case or a lot of other cases which will cause them to put CO2 into your belly so they can take a visual look. So yes. We have to paralyze you doing that.
When you get your gallbladders taken out, that's a big one that, they put a whole bunch of CO2 into your stomach and they, we like to call it insufflation. And, we like to paralyze you because they go in and they have the trocars. You don't want to get hurt, so that's the reason why we paralyze you so you can't move. Appendix is another one. Same operation, but, different body part, but they blow you up on the inside. They put the trocars in. You don't want a whole bunch of moving. You don't want people kicking their legs and doing some of the things that you do involuntarily when you're asleep. You'll still do those things when you're asleep under anesthesia if you're not relaxed or paralyzed.
Right. So, what they want to hear the juicy part. Has anything ever happened crazy during general anesthesia when you're putting somebody to sleep? And the answer is yes. Because if you put enough people to sleep, things happen. We don't talk about it, or we act like a duck in the water. We're not going up top, ain't nothing going on, but down low, we paddling real hard, heart rate up. We sitting there like
your mind might be turning 1,000
we sitting there like,
times a minute trying to figure out what's going on. He all right. He all right. That's the main thing. But we're cool, calm, and collected always on the outside.
You got to be cool and calm because you have drugs to help us out.
Absolutely.
And sometimes these patients just get back there and you give them a little of anything and they just stop breathing.
That happened to me today.
And but she lived.
Yeah, absolutely.
All right, then.
Absolutely. And we finished the case.
Yes. So it happens. I've given 25 fentanyl to a patient. Stop breathing. And I'm like, first of all, it's never happened to me. It's such a low dose. I gave 25. This man, I'm sitting over here, I'm looking like, what is wrong with the sack? And that's the first thing you do. Like, so you push the blood pressure, and you're like, maybe it's on the same side. The blood pressure cuff on the same side as a saturation probe.
Right, so it's going to go down.
Yeah, so then it goes to 40, 50 in the wiggly lines, and I'm like, man, that ain't right. But a person who knows what they're doing, I'm saying all this and it's slow motion, but a person who knows what they're doing, they're not looking at the screen, they're looking at the patient. So the next thing I do is look at the patient, and I'd be like, well, Lord have mercy, this dude done turned gray. And guess what? That SAT is real.
Yes, it is.
And that heart rate is about 0 now. So guess what?
We need to do something.
Yeah, so you at calm, you be like, especially if it's a MAC case, you like, hey, you have to tell the nurse, come in, hey, I need you to go over there, I need you to go right now and go get all the stuff we need to intubate with. And they like, they start screaming, and you like, no, everything okay, everything good.
Just
but yeah, they stop breathing, they cough, they bronchospasm, they laryngospasm, which happens a lot. A lot of these people laryngospasm, and a lot of people are like, well, what's that? Vocal cords just closed.
Yep.
And you can't get nothing through there.
Nope. Positive
pressure will pop it open.
Yes.
Sucks will pop it open.
Yep.
But what we do, more than likely, we do positive pressure.
Yeah.
And, anything hit those vocal cords, it can be a little saliva, and
it shucks.
They just shut off. That's the body mechanism for protecting the lungs. So that's what happens.
That's
but
the cough.
Things happen during general anesthesia. Anything happen to you?
Yes. So I was when you said bronchospasm, it made me think when I was doing my residency, I go in to induce a patient. And I mean, this is my last year. This is like the last couple of months. And by that time, they're just like, go, take the patient, go. So go in. She's healthy lady, and did not smoke, but someone that lived in the house with her smoked with her. Smoked in the house, but she did not herself smoke. So go in to, induce her. Give her a lidocaine, give her a propofol, give her a little bit of fentanyl. And I only gave her a little bit because she was so heavy, and I didn't want her to stop breathing because it was just going to be an LMA.
Right.
So go in, and I'm trying to bag her. I can't get any air in. And I'm like, okay, so I readjust my grip. I'm thinking about this thing. I can't get any air in. Well, she's heavy, so her sats start to just drop. Mm-hmm. And it was just like you said, I'm seeing 70, 60. And I'm like, go get Dr. Peterson. And they, the people are just sitting there looking at me because they're like, she's, fourth year. Like, this is, she's done. Mm-hmm. Like, she's good. She never has problems. And I'm like, no, seriously. Go get Dr. Peterson right now. By the time Dr. Peterson gets in there, like, her sats are in the 30s. Her, heart rate is in the 20s. I still can't, bag this lady. And luckily, I had some glyco. That's a medicine to make your heart rate go up. I gave her that. Dr. Peterson came in. He couldn't even intubate her because she had bronchospasm. And, her cords were just closed. We ended up having to give her some sucks. Mm-hmm. And everything was fine. Mm-hmm. The sats went back up. Our heart rate went back up. We had a nice blood pressure. We were even able to do the case. It wasn't even a big deal. But even he said he's never seen a bronchospasm that bad. And that happened to me during my training. I was like, ooh. I went home and thought about that one for a long time.
Well, I want to share one during my training. It didn't happen to me, but it happened to a colleague of mine while we were in Florida. Scariest patients to take care of, and I don't care how many people say, oh, I do them every day, which I was doing them every day. Pediatric patients. Ooh. You have babies and you have these kids. They come in there, they 5, 6 years old. And what happened this day, one of my colleagues, they were in the room, and this surgeon is particularly fast with doing TNA, tonsils and adenoids. Mm-hmm. So he took out the tonsils very fast, and he said, I don't like for the patients to be intubated. So me and him used to get into it.
On a TNA?
Yes.
Okay.
So me and him is getting to it, right? I'm like, I'm intubating the patient. I don't care what you say. You know, who knows?
And that's good practice.
Right.
That's safe practice.
So he intimidated this person, and they put an LMA in. And yes, they put an LMA on the TNA.
TNA?
They removed the tonsils, and he hit a major artery in the back. And this 5-year-old,
oh my gosh.
they couldn't ventilate, so they had to pull that out. And they tried to intubate. The anesthesiologist called in. They tried to intubate, couldn't intubate. And they tried to bag her. The mouth kept filling up with blood. The lungs started filling up with blood, and nobody could see anything. And what happened was, I think they had a coma tube where they brought in the paramedics, and finally, I think they pushed it down in there, and baby died in the surgery center, 5 years old. They tried blood transfusions, maybe, I think, when they got to the hospital and everything, but they had to find the source of the bleeding, which was a major artery, and that baby died at that place.
Sad.
And I think the saddest thing was watching and the doctor have to go out to on a simple case that could have been avoided by putting a
ET tube in.
ET tube in, that the surgeon pressured her to put in an LMA, and it was a problem and ultimately the patient died, which, these things happen in anesthesia, and it's nothing that you can do about it. But your license is always on the line, so you do the most prudent thing, which is, it may be a little much. It may take an extra 2 minutes to intubate somebody, 30 seconds. But don't let anybody pressure you where it's going to put your license at risk, right?
Right.
We are Vascular. We provide anesthesia services for office-based anesthesia, ASCs, and even small hospitals. Thank you for the opportunity that you allowed us to come in to your families to service you while you're sleeping with excellence. Thank you. We are Vascular.
We are Vascular.
I fell asleep last night. Drops on my pillow.
Another question. If you get put on anesthesia, are you going to die? And would you know that they've died? It's just a question.
That's an interesting question.
Yeah, so if you put on anesthesia, and if you were put on anesthesia and you die, would you know that you died? The patient or anesthesia? That's like a twofold question. Okay.
Right.
Well, we know when you died. If your heart stops, yes, we know what's going on. If your blood pressure bottoms, yes, we know what's going on. We got epi, we got atropine, we got a lot of drugs back there to kind of combat that, and we'll see it coming. If you're under general anesthesia, is it because of anything? Will the patient know that they died? I don't know. I haven't died under anesthesia, so I don't know. I haven't asked anybody, because usually if something happens, you're not be like, hey, buddy, you died.
Guess what? You died.
Yeah.
And we brought you back. We kind of don't do that. It's kind of a part of the job.
Yeah. Did you see the white light?
Did you go to the light?
There it is. Usually, I'm gonna tell you right now, that's one of the anesthesia secrets. If somebody asks you, did you go to the white light, and did you go to it, you probably died. Yes, probably something happened. And they start talking about it, they be out there, what are you talking about, a light? Yeah, I'm just playing with you, man. Yeah,
no
probably
worries.
something happened. So would the patient know? I don't know. Will we know? Yes. And majority of the time, it is a very slim chance, 0.000 chance of you dying on anesthesia. And we talked about, I think, the first episode. It's your primary reason for coming in there is what happened to you. It may be cancer. It may be anything.
Right.
Maybe you shot up 100 times or stabbed 200 times. It's probably what you died from, not from general anesthesia. It's very, unless it's malignant hypothermia, which cases have happened. Where you have 16-year-old females go in for, bilateral
breast augmentation.
Yes. So they get a little boob job, I guess that's what we call it, and malignant hypothermia, and
And they had no idea because no one else in the family knew about it or had problems with it, or no one knew why Grandpa just all of a sudden just burst out into flames during his surgery. They just thought it was a freak accident.
Yeah.
But it does run in families.
Yes, it does. So it's a question we asked them again, and you have problems with anesthesia, any family members to that sort. So some of them say, yeah, something happened to my cousin or whatever, and she basically temperature went crazy when they induced anesthesia on and turned the gas on, and a lot of things happen. So do some people die from general anesthesia? People die from more people die from car wrecks, airplanes, crashing, things of that nature than from general anesthesia. So the question, do people die from general anesthesia? People die from everything. So it has happened.
Absolutely.
You've had people go in and, unfortunately, everybody in the church ain't Christians. And everybody who has an anesthesia license, sometimes they don't know how to put people to sleep. So it happens. It's very few, that it happened to, but, it happens.
I will say this, though. If you are advised to maybe have your procedure later because you're not fit for surgery, or as we like to call it, optimized for surgery, especially if it's an elective procedure, you might want to reconsider having your procedure, because a lot of times what happens is people have surgery when they're not in good health for surgery, and someone from anesthesia will tell you, like, your heart's not good. You need to, go see your cardiologist. You need to, take some medications. You need to wait a little. That's what happened to Kanye West's mother.
Yes, it did.
She wasn't optimized for surgery. A lot of your patients that are dialysis patients, they are notorious for skipping dialysis, 5 days in a row, and then they want to come and have surgery, and you need to go have dialysis first because all of your electrolytes are off. You have a whole bunch of extra fluid on you, and then you're coming and you're trying to get this procedure done. Well,
you're in overload.
You're in overload. You're like a disaster waiting to happen. And so if they say, don't get this procedure done today, wait a little while, you should really consider it.
It's unfortunate that a high number of dialysis patients, they are pretty much the ones that come in and complications happen during anesthesia, or they just have a stroke, or they have a heart attack. A lot of different things happen when you have dialysis patients.
Speaking of, I had a patient today, and we gave him the option to not have his procedure today or to do it without anesthesia, or just local anesthesia, because he had just had a heart attack 3 weeks ago. He had had a heart attack 2 months before then. He had been in the hospital, intubated for 4 days. I mean, he was just a disaster waiting to happen. Luckily, he was okay with just having the local anesthesia, and he did fine. But we absolutely did advise him, maybe that's something that you want to wait a little bit on, because you don't have to have this right now.
Right. Okay.
You might save this life.
So those are just a few things that we want to talk about today with our show, just to inform the public on what we're doing. Hopefully we're going to try to get into some of these facilities and have the camera follow us around so you can see the pre-op, post-op, and sometimes during the surgery. So
that's going to be fun.
That's going to be so fun. And you get to see how we do in anesthesia. We're not going to over-dramatize everything, but we'll let you see, the basics of how we do things when we perform anesthesia on a patient. But, hey, this concludes Insomnia. I'm David Prophet.
I'm Crystal North.
And this is Insomnia, vascular anesthesia. Have a good night.
Peace.
I fell asleep